All right, so hi, good morning, everyone. So now here again with another session. So I'll just start in a while. Let's wait for a couple of minutes for the people to join in. All right, so earlier session we have started with our PYQs, right, of all the previous years of this FMG examination. Good morning, Bache. Good morning, FMG 2026. Oh, wonderful. So today, continuing with the same part, I'll be discussing the rest of the MCQs as well, right? So in the very first session, we have discussed the MCQs of your previous years, and that was January 24. We have discussed July 23. We have discussed. Then we had a discussion on the next year was now. Today we are supposed to discuss about the good morning fly high doc. Good morning. So FMG January 23 is the paper I have for today. Right, so let's discuss these MCQs, and then year by year, let's try to figure out all of them. And I'm very sure in the last session, what all MCQs we have discussed, you have gone through those notes and you have gone through your workbook, whether you have studied from me or from somewhere else. Make sure that you are just going through all the notes. That will be very much required, right? So we had made some notes also in the last session. Okay, so I'm trusting you that once the questions are done, you are not trying to mug up the questions and trying to learn the basics, right? So don't mug up anything. It will not be a difficult task if you try to just understand the concepts and then try to answer the questions in your exam. All right, so Samuel, Arohi, okay, Himani and Alka, okay. So let's start. Just give me a moment. I'll just put this phone onto the stand so that we can uninterruptedly we can discuss the questionnaires. Just give me one moment and I'll be just starting with this. Okay, so in a while I'm just starting with you. All right. So now let's start. Let me just okay. So I have those should be fine now for everyone. Okay, how is this one? Just check if you all can easily see the screen here, if it is fine for all of you. I think the screen is fine and you all can see the questions very easily, very properly, right? Is it fine? If somebody can please comment. Is the screen visible to you? Very proper one. Arun, Saurabh or the Vikant. Okay. Is it okay? Shall we start with this? The graffiti mind. Okay. Shall we start with this? All right. So now with the FMG 23 MCQ, we start from the very question number 1. Right. The first question we have here, what type of displacement is most likely observed in a 60-year-old female patient who presents with pain and swelling in her left wrist after falling on an outstretched hand, right? And exhibits a dinner fork deformity upon examination. Now, please tell me, when you talk about this dinner fork deformity, what kind of injury are they pointing towards? If it is the dinner fork deformity, what kind of injury are we talking about? What is the diagnosis when it is dinner fork deformity? Good morning, Daud Wani. Okay, good morning. Batao, what is the diagnosis here? If it is a dinner fork deformity, so what should be the diagnosis? What do you say? What should be the diagnosis? Okay. So diagnosis, Smith, oh no, graffiti mind, dinner fork deformity with Smith fracture? Not really. It will not be a Smith fracture. What it can be? Colles, always confusion. Why confusion? We'll talk about this. So diagnosis has to be Colles fracture, right? It has to be Colles fracture. So have no confusion in this. See, I'll explain this to you. Whenever we have to differentiate between the Colles and the Smith fracture, the very important thing. See, We always should be very clear about this. When you talk about the fractures of the distal end of the radius, okay, fracture of the distal end of radius, we should be very clear upon this part, that fracture of distal end of radius, they can be of two types, right? They can be of two types. What are the two types? One is when you call it the extra articular injury. One is what you call as the extra articular fracture, or the other one we say is intra-articular fracture. Extra-articular and intra-articular fracture, right? Extra-articular, intra-articular, what does that mean? See, when you look at distal radius, let's say this is distal radius here. When the fracture occurs away from the joint line, what is a joint line? This is joint line, right? Joint line means the radiocarpal joint, right? Joint line means the radiocarpal joint. If the fracture line is away from the joint line, it is extra-articular. And when you see this, the fracture line going like this or inside like this or like this is intra-articular, right? So extra or the intra-articular fracture, right? Now, how to make a difference in the different types of fractures? When you say extra-articular, we have two kinds of injuries that can happen here. Number one is Colles, right? Number one is Colles. And the second fracture we can think about is Smith. These two are extra-articular fractures, okay? And when you say intra-articular fracture, the fracture line which is going to breach the radiocarpal joint, then we again have two. One is Barton and other one is what you call as the Schoffer, right? Barton and Schoffer. Colles, Smith, Barton and Schoffer, right? In your exams, most often the asked are your extra-articular fractures. This one, right? Most often are these one. Why so? See, extra-articular fracture, why it is more commonly happening as compared to intra-articular? This extra-articular region, this one, is the metaphyseal area of the bone, right? That is a soft area of the bone, okay? Metaphyseal area are the cancellous region of the bone and they most commonly get fractured. Sorry. So metaphyseal injuries, they most often get injured, right? They are metaphyseal, they are soft, they are cancellous, so they get fractured. Now, we should be able to understand the difference in the Colles and the Smith, and don't get confused, right? Like you just said, I get confused here. So don't get confused. Colles and Smith, what is the basic difference? Now let me show you the pictures over here, right? Have a look on the injuries and let's try to figure out the basic difference in these two. I'll just show you something. So look at the images which will help you to understand the difference. Look at these two images. Okay, look at these two images. In these images, which one is Colles, which one is Smith? First of all, we all should be able to analyze that both the images given to you here, they are the lateral views, right? This is a lateral view. This is a lateral view. And in the lateral view, always figure out that which one is your palmar side, which one is your dorsal side, right? Which one is your palmar side and which one is your dorsal side, right? So right means you are saying number one, we have image number one, we have image number two. So in the image one, if you can make out, this is the shadow of the thumb, right? The first metacarpal we have, right? The first metacarpal we have. So this is the shadow of the thumb, okay? Shadow of the thumb over here. Now, if it is a shadow of the thumb, look at your hand. If you take an x-ray of your wrist like this, so thumb stays in front, this is the palmar side, right? This stays as the dorsal side. So this one is palmar. Now, look at this one. If this is the palmar one, this is the palmar side. This too, in the image 2 also, it is the palmar side, right? Now, the very first thing, whenever you're getting a fracture at the distal end of the radius, the very first thing to be seen is whether the injury is intra-articular or extra-articular, right? Whether the injury is intra-articular or extra-articular. Now, look at this joint margin here. Look at this joint margin over here. So, joint margin here is clean. This joint margin is fine. There is no fracture line into the joint line, right? Have a look on the second picture. In this picture also, you have the joint line which is clean, right? The joint line is fine. So, if the joint line is okay, that means it is again an extra-articular outside the articular margin, okay? So, what is the basic difference when you talk about the Colles and the Smith? What is the basic difference? Difference is of the displacements, right? The difference is always of the displacement, okay? So, in Colles, what are the displacements seen? Always remember the displacement of Colles by the mnemonic LIDS, lids. LIDS, lids. What are the displacement? Total of 6 we can see, right? L here stands for lateral displacement and lateral tilt, lateral displacement and lateral tilt. I is impaction, right? I is impaction. D is dorsal displacement and dorsal tilt. D is dorsal displacement and dorsal tilt, and S is supination. S is supination, right? So the major, most important is always to look for the displacement of the fragment on the dorsal side. And when you look at the Smith fracture, Smith is just reverse of Colles. Simple. If instead of displacement on dorsal side, the displacement is on the volar side, or you can simply say palmar side, right? If it is on volar side or on the palmar side, it becomes Smith. Okay, so displacement will be the most important factor to differentiate the two injuries, dorsal and palmar one, right? Now look at these injuries. If you just see the palmar side here, the fragment here on the distal part of radius, it is pointing towards your palmar side. But if you look at the second picture, here this fragment is going towards your dorsal side, right? So if it is coming on the palmar side, what is the diagnosis now for the X-ray A or the X-ray 1? Now what do you say? In the X-ray A, what is the diagnosis? If you can make out this one. X-ray 1 is Smith or Colles. Now there should be no confusion. Palmar side and dorsal side. There should be no confusion now. So what do you say? Colles or Smith? What do you say? Colles or Smith? So palmar 1 is palmar side. So palmar means Smith now. Very good. So now there should be no confusion, I hope. This is Smith and the second one going on the dorsal side. So it goes in favor of Colles. Okay. So always remember, the deformity basically is based on the displacement only. Now when you look at the Smith fracture, a straight line going straight and straight and straight and straight, and suddenly there is a depression like this, right? If you see the other one, it goes straight and straight and straight, and there is a dorsal kind of displacement here, right? So when you have the fragment going anteriorly, it is giving you a garden spade deformity. This one is your garden spade deformity, but you see other one, this is what you call as the dinner fork deformity. So why does the dinner fork deformity happens? Because the fragment goes on the dorsal side. That is a dinner fork deformity, right? So garden spade, the shovel, or the dinner fork deformity. I hope it will not be having any confusion now, right? So no confusions now. I hope this should be fine. So the very first question is asking you that why a dinner fork deformity upon examination can be seen. So do we have a ventral displacement? Do we have a ventral displacement or dorsal displacement? We have a dorsal displacement, right? So dorsal displacement of which bone? So it is happening because of radius only, not because of ulna. The fracture is in radius. So we know now that we have, we have got 6 displacement, L, I, D, S. So these are the 2 displacements of Colles. So Colles is going to lead to the dinner fork deformity, right? Is it fine? Graffiti mind. No mistakes in the exam. No mistakes in the exam. And I told you the very first thing to be seen is always this one, right? So LIDS, remember this. If it is medially displaced, if it is in palmar displacement, if it is in pronation, then it has to go in favor of Smith. These are Smith. Okay, these are Smith injuries. All right, this has to be Smith injury. So very first one we have as Colles fracture, dinner fork deformity. This one you have diagnosed very well already in the last session. This has gone well, right? So what is the most probable diagnosis for a 17-year-old male patient who visits the clinic with a painless lump on the outer side of his left knee as depicted in the radiograph? What is the diagnosis? You can easily make out a lump over here, which you can see the visible growth is this much. The visible growth is this much, and yeah, so it has to be osteochondroma. Absolutely right. This has to be osteochondroma. So when you will see the osteochondromas on the X-ray, they will appear smaller. But when you will feel them, there will always be a cartilage cap over them, right? There will always be a cartilage cap over them. So always remember, osteochondromas, they look small on the X-rays. Yeah, it is a pedunculated osteochondroma. Very, very good, right? So cartilage cap, it always grows less than 2 centimeters. Cartilage cap is less than 2 centimeters, right? Always remember, this is the pedunculated variant. You are absolutely right. This is pedunculated osteochondroma. Yes, you're right. It is pedunculated osteochondroma. Very good. So you can easily diagnose this. Now, this one, if you can make out the question number 3 here. An elderly patient with the presented deformity was brought to the OPD. What is the likely diagnosis? So what is this deformity which you can see? If you can make out. The wrist going into the lateral kind of deviations, fingers going towards the ulnar side. Okay, so how do we make it out? What exactly is happening here? So one here, one here, one here, like this. Can you make out what is happening? The D, rheumatoid. What is the name of this deformity? When the fingers, the hand are deviated like this. This is simply called as, what is the simple name given to this? Ulnar deviation of fingers and the radial deviation of the wrist. This is called as Z deformity. Very good. It is called as the Z deformity, rheumatoid arthritis. Very, very good. Okay. Very nice. What is the probable diagnosis for a 20-year-old patient who has got pain and swelling in the middle finger around the proximal phalanx as depicted in the X-ray? So, windswept. Oh, windswept is the deformity which is said in the legs area or the knee area or the toe area, right? Windswept means that all the fingers are pointing in the same direction, but here the deformity is not confined only to fingers, okay? The deformity is always involving the wrist joint. This is the place from where the deformity starts, right? So this is Z deformity, absolutely right. What is the diagnosis here? 20-year-old patient who has got pain and swelling in the middle finger around the proximal phalanx as shown in the picture. Now what this should be, you can see the finger of a patient is being involved here, right? You can see a lesion here in the finger. What this can be? Any probable diagnosis for this? Any probable diagnosis for this? So this has to be what? A lesion in the Ewings. Oh, come on. Ewings inside the finger. I told you. Clast. Why only a clast means osteoclastoma you are saying. GCT you are saying. Ewing sarcoma. Oh, come on. Don't do that. Don't do that. So for tumors, I have osteoclastoma. No. Beta, dekho, kiska X-ray hai? What is the X-ray given to you? It is of the hand, proximal phalanx. Which is the most commonest lesion of the phalanges? Which is the most commonest lesion of the skeletal lesion of the hand? GCT? No. Never. It is enchondroma. Absolutely right. Dekho, tumors may just follow the simple rule. I have already given you this thing. But tumors may already follow the simple rule. What is the simple rule for tumor identification? 3-step approach, no? We discussed last time also. What is the step 1? For any tumor identification, what is the step 1? The step 1 is simple, to figure out the location of the lesion. Whether the lesion is epiphyseal, whether the lesion is metaphyseal, or whether the lesion is diaphyseal. Step 1, right? Step 2, the step 1 is location. Step 2 is to figure out the nature of the lesion, whether it is benign or it is malignant, right? Then we go on to the step 3, and the step 3 is to figure out the special feature of any lesion. For example, every tumor is going to show you one peculiar feature which is usually not seen in other lesions, like soap bubble appearance, like sunburst appearance, like onion peel appearance, right? Sclerosis. Okay, so always follow this 3-step approach. Never change the sequence. Step 1 has to be location. Step 2 has to be the nature. Step 3 has to be the special feature. Right? That is the way to go for any tumor. Now, other than these, just to simplify, the most commonest lesion, if an X-ray of the hand is given to you and it is about the bone tumors, in the hand, the most commonest skeletal tumor of the hand is enchondroma. Right? That is a cartilage lesion again. Okay, most commonest lesion which is given to you in the hand is enchondroma. If by chance they are giving you a vertebra, if by chance they wish to ask you something from vertebra, so in the vertebral body, if you see multiple, these kind of white lines inside the vertebral body, the most commonest lesion you are going to say here is hemangioma. And what is that appearance called as? These lines here, what are these called as? The jail bar appearance. Or what you learn as the corduroy appearance, right? Jail bar or the corduroy appearance. Okay, so remember this. In a long bone lesion given to you, figure out location, epi, meta, dia, nature, and the special feature. Now always have the DDs in your mind, right? Always have DD in your mind when you're talking about a bone tumor. Okay, and let's say you have to differentiate on the basis of location, right? Let's say like that. So in the location, please remember, if it is an epiphyseal lesion, right, something given to you in the epiphysis, we can have 2 lesions, right? In the epiphysis, we can have 2 lesions. One is giant cell tumor, osteoclastoma you say it, right? Or the chondroblastoma. What is the basic difference in these two? See, GCT is seen usually in adults, age group 20 years to 40 years, right? Chondroblastoma on the other side, chondro, cartilage, right? So it has to be in a child. Okay, so if you are able to see a growth plate, if you are able to see on your CT scans, on your MRI, on your X-ray, if you are able to see the growth plate, it goes in favor of chondroblastoma. And if the patient given to you is an adult, then it goes in favor of giant cell tumor. This is epiphyseal lesion, right? That has to be the epiphyseal lesion. Second is, if they say metaphyseal, there are few lesions which are common over here, right? There are few lesions which are common over here. Okay, so metaphyseal lesion, if you say benign category, what all are the benign tumors we can talk about? It can be non-ossifying fibroma, it can be aneurysmal bone cyst, it can be unicameral bone cyst, it can be your osteochondromas, right? If it is going into somewhat aggression, mild aggression, we know it has to be osteoblastomas, right? And if it is purely aggressive, purely malignant metaphyseal tumor, then it has to be osteosarcoma, right? It has to be osteosarcoma. Now, every tumor, location I have told you. Second thing will be to figure out the nature. So, nature also we have mentioned benign, aggressive, right? Both of these tumor, epiphyseal tumor, what kind of lesions they are? They are benign aggressive. They will destroy the bone locally, right? So, nature also you know. Now, every tumor will be identified by their special feature. For example, osteosarcoma, you know, sun ray appearance, right? Osteochondroma, you know, polyp-like growth. UBC, you know, is a fallen fragment sign. ABC, you know that it is by septated soap bubble appearance at metaphyseal area, right? So this is how it is supposed to be. Hi ma'am, good morning. Okay. All right, you got the point here. Can you assume osteoclastoma is only on epiphysis? Dekho beta, bone tumors, these are tumors. That's a very good question you're asking me. See, I'll share something with you. See, when you're talking about bone tumors, no, please understand. When you are talking about the bone tumors, please understand this. Bone tumors are something which follows only one rule, right? And there is no rule. As simple as that. Bone tumors follow only one rule, that there is no rule, right? These are tumors. But when it comes to your PGME preparation, when it comes to your FMGE exam preparation, you have to understand that we have to learn the basic things first, right? So GCT's most commonest location is epiphyseal, which is usually eccentric, right? Chondroblastoma again is usually epiphyseal, but in you can say certain patients, the GCT can be seen at metaphyseal area also, right? So tumors has to follow only one rule, that there is no rule. But for your exams, for our OPD learnings, for our basic, evaluation of the patient, this is something we all should be able to make out, right? I hope this is fine. So osteoclastoma for your exam, yes, it has to be on epiphysis only. Nobody is going to give you a giant cell tumor which is in the diaphyseal area, metaphyseal area. That will not be happening. That is for sure, right? That you can take for sure. All right. So location, epi, meta, and dia. And now let me tell you about the diaphyseal lesion as well. So now let's talk about the diaphyseal lesion. In diaphyseal lesion, when you talk about the benign lesions, we have two. Benign lesions are which ones? Osteoid osteoma and fibrous dysplasia. And osteoid osteoma is the most commonest true benign bone tumor, right? Fibrous dysplasia, where you get the questions on Shepherd-Crook deformity, bent of the bone, right? That is one of the MCQs for your exam as well, Shepherd-Crook deformity. When you say malignant, we have got Ewing sarcoma here, the onion peel appearance or the lamellated appearance, okay? So that is the way to go with the bone tumors, all right? Hand lesion, osteochondroma. Hand lesion, FD is here, na beta. This is FD, the benign lesion of the diaphyseal area. It is fibrous dysplasia, Shepherd-Crook deformity, okay? That is Shepherd-Crook deformity. Now see, when you talk about fingers, I just told you the most commonest lesion, most commonest bone tumor we have is enchondroma, right? And why you all should be knowing about this osteochondroma? You all should know about this osteochondroma for that one reason. Enchondromas, the chondroma, they are troubling lesions, right? Chondromas, they can keep on growing. Cartilage keeps on growing and that may convert into malignancy, all right? So always remember the syndromic associations of enchondroma. And what are they? Syndromic associations. One is Ollier's disease, right? Syndromic association number one is Ollier's disease. What is that Ollier's? Ollier's disease is when someone is having, multiple enchondromas. Ollier's is when somebody has multiple enchondroma, right? And the second one is Maffosi. And the second one is Maffosi. What is that Maffosi? Maffosi is whenever somebody has enchondromas along with hemangiomas, right? Mafosi and Olliers. So if in your exam, instead of just one finger, multiple fingers are given to you with the lesion, right? Multiple fingers are given to you with the lesion. We know we are talking about Olliers. But if in your exam, along with the fingers, they give you one skin lesion, and you can see hemangiomas over here, right? Then we know we are talking about Mafosi. So enchondromas are the most common skeletal tumor of the hands, right? They are the most common skeletal tumor of the hands. I hope this point should be fine with everyone, right? Most common skeletal tumor of the hand, right? Is this fine with everyone? Is this fine with everyone? Those who are confused, those who are not confused. Now I hope the approach to the bone tumor becomes simple. Is this fine? Shall we proceed with the next one? Okay. So Zafa has answered, yeah, Mafosi. All right. So I'm going to the next one. All right. So how would you treat a 80-year-old woman who slipped and fell in bathroom? Olliers, double L, multiple and double L, mnemonic. Okay. You can remember it any way you are comfortable, right? That is very true. So how will you treat a 80-year-old woman who slipped and fell in the bathroom, resulting in pain and instability to walk due to left hip injury? Right, left hip injury. So in the left hip, in the X-ray, I can see there is a fracture on both the sides, not only on the left hip. She has no previous history of OA, no arthritis. During the examination, it was observed that her left lower limb is shortened and little externally rotated. X-ray is given below. What is the approach? What do you see? What do you see is the fracture neck of the femur. What do you say is the plan here? What should be the treatment plan? What is the treatment plan? And this is one of the very common question asked in your exam. Bipolar. There is no option of bipolar. What is that bipolar? Choose from the option given to you. Dawood Wani is saying hemiarthroplasty. Okay, you want to go for hemiarthroplasty? Fine. Fracture neck of femur, very true. So hemiarthroplasty or CC screw fixation, or let me put it like dynamic hip screw. Which one you want to go for? Hemiarthroplasty with bipolar. Okay. So option C, right? Perfect, right? So I believe B, Mayer's operation, never. Mayer's operation for here, never do that, right? That will never be the right choice. See, Mayer operation, A, internal fixation with CC screw. No, not at all. These two are wrong here. See, when you are talking about the fracture neck of the femur, we should be very clear about a few basic rules. When you talk about the fracture neck of the femur, we should be clear with very important rules here. No, beta, A is not right. A is not right. See, let's learn the principles, okay? Let's learn the principles of fracture neck femur treatment. Right? The treatment plan for the fracture neck of the femur. I'll just simplify this. Right? Fracture neck of femur, the treatment plan. See, the very first question you are supposed to ask any of your patient. I hope this is visible. Okay. So, the very first question when you are having a patient of the fracture neck femur, how to decide the treatment? It depends on just one question. It depends on just one question. What is that first question? First question is the age of the patient, right? The question number one is the age of the patient, right? You will have to ask the age of the patient. If they say the age of patient is more than 65 years, right? In our question, our patient's age is 80. If they say the age is more than 65 years, treatment is only one, and that is replacement. More than 65, no second question to be asked and thought for. It is replacement, okay? Now, what kind of replacement is preferred? Always remember the preferred plan is always hemiarthroplasty. The preferred plan is hemiarthroplasty, right? Preferred is always hemiarthroplasty. But in case if there is a mention or in the X-ray you can see that arthritis is present. If arthritis is present, then what is the plan? Then the plan goes in favor of total hip replacement. If arthritis is present, the treatment has to be total hip replacement, right? So preferred is hemi, but if there is a mention of arthritis, then we go for total hip replacement. I hope this is fine with everyone, right? I hope this is fine. More than 65. So first question and the only question to be asked, right? It has to be the age of the patient. What if the question mentions history of OA and option given both THR and hemi? That is what I told ना ऋषि. देखो तो इसको preferred hemi है, अगर arthritis है तो THR है. Simple. Okay. But if the patient's age given to you, they say it is less than 65. If the age of the patient given to you is less than 65 years, right? In any patient less than 65, we prefer to save the original head, right? We prefer to save the original head. Okay. we prefer to save original head. Now, how to save the original head? It depends on my question number 2. Right? Now, how to save the original head? It depends on my question number 2. Now, what is the question number 2 I'm going to ask? I'm going to assess for what is the status of the head as of now. Right? The question number 2 has to be the duration of the fracture. And this I wish to know the probability of AVN, which I can best assess by MRI here. Right? Duration of the fracture I want to know from here. Okay. In the duration of the fracture, now if MRI says there is some necrotic patch, there is no necrotic patch, and we divide the plan. So ultimately the goal is same, that we have to save the original head. Right? The goal is same, we have to save the original head. Now how to save the original head? It depends upon if AVN is there, some part is getting necrotic, some is not getting necrotic. If it is saying a early presentation, which means there is no necrosis at present. Right? Early presentation simply means there is no necrosis being, seen at present, the early presentation. What is to be done? If now the early presentation is there and there is no AVN, my aim is simple fixation as soon as possible. Right? Fixation as soon as possible. How to fix? Now it depends upon what kind of fracture we have. If we have intracapsular injury, the subcapital fracture or the transcervical fracture. If we have the subcapital fracture or the transcervical fracture, these are which kind of injuries? These are intracapsular fractures. Right? These are intracapsular fractures. Okay. So intracapsular fractures, and these intracapsular fractures are at a risk of developing AVN. Right? And that is why we prefer to fix them by the method of close reduction and internal fixation. And how to do that? What are the implants to be used here? They are cannulated cancellous screws. Okay. And if we have the extracapsular fracture, which one is that? Basicervical. Right? You know that basicervical is a extracapsular fracture. If it is an extracapsular fracture, then we use a proper implant, open it well, reduce it well, and fix it well. The preferred one is a small DHS, pediatric DHS. Right? So aim is, if there is the patient less than 65, we have to save the original head. Right? We have to save the original head, and we have to check for the avascular necrosis. If AVN is not present, fix it as soon as possible. How to fix? The question is depending upon the type of injury. If the type of injury is intracapsular, don't open it. Right? Don't open it and fix it without opening it. The CRIF, cannulated cancellous screw. Right? If it is extracapsular fracture, we go for dynamic hip screw. Right? Now, if option A was also correct, but only if age was less than 60. See, it is the same thing, no? Age is the most important criteria. Age, if it is less than 60, 65, then we have to fix it. Right? You are absolutely right. So treatment is based on age. Now, if there is a late presentation, if we have the patient who is coming to you as a late presentation, that means necrotic patch is there, then we have two options. One is Mayer's pedicle graft. Please don't forget this. This is Mayer's pedicle graft. Pedicle graft is something with a viscolarity, with a vascular supply. And which is the muscle this Mayer's pedicle graft uses? It is quadratus femoris. Right? It is quadratus femoris. And there is an osteotomy which too can be done, and that is called McMurray's osteotomy. There are others as well. The McMurray's osteotomy. Right? The McMurray's osteotomy. These are two options. So these are the options when the patient is showing you some necrotic patch, late presentation. Okay? Don't miss out this chart. Don't miss out this chart. This is a plan, and this is one of the most frequently asked MCQ in your exam as well. I hope it is very clearly visible to everyone. You all can make out. Right? So don't miss out this chart here, this flow chart here, and it has to be learned by heart. One of the most frequently asked, questions in your exam. Okay. Now, please understand, in variable sources at multiple places, you will be finding different kind of options for different fractures. Right. So always remember, orthopedics is a branch which gives you a lot of scope to have a lot of experiments so that we can give the best of the treatment to our patients. Right. So variable authors will have variable kind of opinion. But we have to stick to what is the best plan for us to qualify our exam, to crack our exam, FMGE, NEET, PG, or INSET, whatever it is. Right? So follow this flow chart. Don't deviate away from this flow chart for any question which is coming to you for fracture neck of the femur. Right? I hope it is fine with everyone. I hope it is fine with everyone. Okay. So no mistakes. This flowchart is here. I'll just post it on my story as well. This image I'll post on my story as well. So you can download from there or in the orthopedic group as well. So I can download from there. You can just download from there itself. I'll be just posting it, right? So this is a very, very simple flowchart, right? And just follow this, okay? So please remember the last line, which I definitely want you all to remember. The most commonest complication following the fracture neck of the femur, most commonest complication following the fracture neck of the femur, it is avascular necrosis followed by non-union. AVN is overall the most commonest complication, right? And please don't just confuse ever non-union and malunion. Please understand, bone is not uniting. That means there is something wrong with the vascularity, right? So AVN and non-union goes hand in hand, not the malunion, right? It is not the malunion which goes hand in hand. All right. So let's now. So these were the questions of your which you wrote before this also. What I have written before this one. All right. So I'll just post on my story. That's not a problem. Okay. But again, बच्चों, for everyone, I'm just telling you very, very honestly, malunion, non-union में confusion है. Oh, confusion क्यों है? देखो, malunion. What does that mean? Malunion. Malunion. Union, and this is in mal. Mal means what? Non-anatomical position, right? Malunion simply means when the bone has united in the non-anatomical position. Now, is it a good thing or a bad thing? See, understand, malunion is a surety that bone is uniting, right? But not in the anatomical position. Okay, so when a bone is uniting in a non-anatomical position, if it is acceptable to you, you can leave it. For example, when there is an injury of the clavicle, right? What is the most preferred treatment? It is conservative. We just give a figure of 8, right? And we know that every single case of clavicle is going to have a malunion, right? It will always have a malunion, right? But then it is acceptable to us because clavicle is not taking any part in my shoulder mobility. It should be free from that, right? So we don't get worried about that thing, and we always, leave it like that. So malunion may be the reason for a deformity which is acceptable to you, not acceptable to you. Where the malunion should happen? Malunion is a surety, no? And malunion is the surety means the bone at that particular point should have a very, very good vascularity, right? The metaphyseal areas of the bone are the commonest site where we get the most common complication as malunion. Why? Because metaphyseal areas are cancellous bones which have a high vascularity, right? So every metaphyseal fracture, for example, supracondylar humerus, Colles fracture, Smith fracture, Boxer's fracture, Jones fracture, what are these? These are all metaphyseal injuries, right? So metaphyseal injuries usually unite. If they are not uniting in the anatomical position, they give us deformity. The gunstock deformity of supracondylar, dinner fork deformity of Colles, garden split deformity of Smith. Common in all of them is the location, that is metaphyseal. Okay, so malunion may not always be a trouble for you, maybe a reason for deformity which might be acceptable, which might not be acceptable. Non-union means when the bone is not uniting at all, right? Why a bone should not unite? Two main reasons. Why a bone should not unite? We have two main reasons. Number one, vascular compromises, right? When there is a vascular compromise, okay? Oh God, sorry. So why a bone should not unite? When we know that bone has got a vascular compromise, right? Or there is too much of movement happening at the fracture site. For example, in lateral condyle, we prefer that we should fix it. Why? Because in lateral condyle, we have got the origin of the common extensors. So the muscles keep on pulling the fragment. So too much of mobility is there, right? Second, when you say the atrophic one, these are called as atrophic non-unions, right? When there is lack of vascularity. Okay, so vascularity means now vascularity is having a lack at the end of the bone, which can have multiple reasons, right? So vascularity is a compromise in which all fractures like scaphoid, like talus, like neck of femur, there is a vascular compromise, right? Pull of the muscle like lateral condyle. Okay, then we have Bennett's fracture. You remember Bennett fracture at the base of the first metacarpal here, right? So that can have a pull of the muscle. Okay, so this causes non-union, right? That can cause non-union. All right, I hope you understood. Oh, Daud, thank you so much for your kind words, right? And good to see you here early morning. This is all you guys that keep us on toes, and now the exam is approaching, so it is my responsibility as well to be with you. Okay, so graffiti mind, is this okay, beta? Now you have understood the non-union. Who posted that question? Zafa. Zafa, is this okay now? Have you understood malunion, non-union? So malunion, it is a union of the bones. Non-union, no union, right? Perfect. Okay. So that is about malunion, non-union. And that is a paper I've taken a lot of time of yours, right? So it is like almost 50 minutes. I've taken a lot of time, and I hope by this time everybody's energies are on the highest level. You all have, you're awake, well awake, and now you can start with your day. Okay. So this is the session, and let's see tomorrow morning as well. Let's meet tomorrow morning as well. I have some more previous year questions. There are a lot many actually. So I'll try to cover up, because once we learn all the, I'll try to keep them daily. I'll keep it tomorrow as well. So these are actually 5 a.m. sessions, right? Earlier there were only the OBGY sessions which were happening at 5 a.m. and now it is OBGY ortho also. So nowadays, as ma'am is taking the ATP session for revision on her YouTube channel, so you all can just be there on the YouTube to revise your OBGY. Yesterday it was session 1, today it's going to be session 2, right? So it is open for all, and you all can just revise the OBGY part as well. So now, good morning. Okay. Rishi, you are in Russia. So how do they call it in Russia? Good morning. It is like something called Dobre Den, that is good day. Or no, Dobre Den. All right, that is something how we call it, no? All right, so we will discuss NEET PG also, INICET also. So Dobre Utro, Dobre Utro, no? Dobre Utro, okay. So that is how. So you guys are the reason now I have to say good morning in Russian also. So Dobre Utro. All right. So thank you so much everyone for being here. It's almost an hour now. You all can start with your day. You all can Dobre Den in Ukraine. Okay, fine. So have a wonderful day. Have a wonderful morning, right? And have a productive day. Make a good schedule for yourself, and just make sure it's going to be a productive day, whether you are studying in your college or you are here in India preparing for the exam on 17th of January, right? See you all tomorrow morning again. And meanwhile, in the day hours, you can be a part of the ATP sessions, right? So OBGY session is going on. Thus with Anya, all right? So okay, so thank you so much everyone, and see you all again tomorrow, right? All right guys, thank you so much. Bye-bye, take care.